Our indication and placement for cuffed and non-cuffed cutters. 5 indications for catheterization. Even the same patient, catheter tip positions are changed by 5 to 10 millimeter between standing and lying. In the standing position, case 1, the tip position changed to upper, but case 2, the tip position changed to deeper. We selected 3 types, 184 non-cuffed cutters using after 2030. We can measure the length of the tip. They can be detected X-ray images. We calculated from the lower edge of the main tracheal bifurcation to the catheter tip. When the tip of the cutters did not reach to the tracheal bifurcation, negative values are indicated. Group B and C, 2 of 12.5 French catheters groups with similar shapes and lengths. But Group C was urokinase coated step tip catheters showed significantly lower rates of catheter dysfunction. Comparing only the negative cases, those are placed in the SVC. So if the catheter tip were in the SVC, to avoid dysfunctions, we need 14 French or over with these catheters. In 2006, Dr. Stonelight indicated the location of the CVC implantation must be in these. On the other hand, dialysis catheter requires sufficient blood withdrawal and return for perfusion. When the catheter tip were in the SVC, we needed 14 French or over, and the 12 French urokinase coated catheter, the groups showed better function than Group B, non-urokinase. My today's 5 contents. We showed our Japanese style indication and placement. About the choice of vein and puncture position. Except in special cases in Japan, we tend to perform a median puncture of the right internal jugular vein rather than supraclavicular puncture. The order of the vein selection is as follows. Choice, right internal jugular to last, right subclavian vein. Here are some of our cases. In the right external jugular vein pathway, the intersection with the subclavian vein tends to be a slightly tighter angle. In neck swelling patients with malignant lymphoma, the right subclavian vein pathway was unavoidably selected. We use the left internal jugular vein route in case in which right neck is not suitable for placing. The left internal jugular vein approach we perform up to placement without removing the guide wire. It is important to use a metal wire combination and to pass safety through the right heart ear. With UK catheters, keep the catheter advanced while proceeding the guide wire and peel away the introducer sheath. This case are large body patients, so we use 28 centimeter UK catheter. There are 2 difficult to pass sections along left internal jugular vein route. Next, about the choice of catheter diameter and tip shape. The choice of catheter inner diameter and tip shape may be determined by each patient dialysis requirements. The option number and position of the catheter side holes is also still inconclusive. The step tip shape is ideal for placement in the left internal jugular vein pathway. In our study, spindle tip and symmetrical tip were equally superior in well-positioned catheters. About this disinfection area, in particular, pacing cuff catheters at sufficient disinfection field were taped to ensure safe and clean. Our first choice of puncture site for dialysis catheter placement is near the middle of the right internal jugular vein. We use only sterile perforated cover for non-cuffed catheter placement. With cuffed catheter, the exit site must be clean too, so small perforated coverings may result in uncleanly operation. In the right internal jugular vein route, we choose the puncture positions with the catheter tip position in mind. There are 2 to 6 centimeter difference between the prediction point from body surface to actual tip position. Anticipate the tip position after placement. We set occasionally the puncture site to 2 centimeter upper. In this case, the predicted tip position on the catheter placed on the body surface differed by approximately 5 centimeters from the actual post-placed position. We always use the bendable tunnelers that can be bent in 2 sides. Guide the catheter body retrogradely. We use the bendable tunnelers goes around connecting 2 smallest wounds. Good tip position depends on the catheter inner diameter. These are DSA frontal and lateral. The catheter tip should be in the green area in the atrium. We may be given too much trust to the frontal view. From the frontal view, the tip of step tip UK catheters was positioned at the upper border of the right atrium. In the lateral image, it was not the ampulla of the CVC, and we should have put more than 5 centimeters deeper than this. In lateral contrast, a tip position of 3 centimeters can be said to be shallow. Before we did only post-digital angiography DSA, but now we examine lateral venography simultaneously with catheter placement. This patient could have the catheter placed in a good position by using lateral venogram during placement. Only the frontal image gives the first impression that the tip was too deep, but the frontal venography showed that the tip was located only at entrance to the right atrium. In addition, from the lateral venogram, we can judge indicates that in an additional 1 or 2 centimeter deeper site is acceptable. In recent years, there are catheters coated with immobilized urokinase inside and outside, fine diameter and functionally good. Now I don't use other catheters. In the UK series, 350 milliliter per minute of blood withdrawal can be removed. We compare the 3 types of immobilized urokinase dialysis catheters, UK catheters. We conducted the following three groups of research. 21 cases of 12.5 French step-tip type cuff cutters, 90 cases of 12.5 French symmetrical cuff cutters, and 40 cases of just 12 French actually rotated non-cuffed cutters. They are UK cutters. We have counted the diuresis as catheter dysfunction. When diuresis was performed with reverse connection due to poor blood removal under 80 milliliter per minute, reverse connection may occur sometimes during 2 or 3 times continuously, but after those, they were never completely unusable. The step tip had very smooth insertion, but there are many cases of step tip catheters in this time. Replacement other catheters to step tip catheters replacement is after fibrin cyst formations were made. So catheter failure frequency was higher than in other groups. By our examination, each patient has their own more perfect catheter. When depressed atrium deeper than proximal 1/3 on frontal image, in our nearly 20 cases, not only by the frontal venographic image, we performed lateral venography at the time of placing, and we are able to secure good deposition. There are so many variations in the shapes of the right atrium, so catheter deposition should be examined on the lateral venography. Next, I'll explain safe-touch plug and repair clamps. This is safe-touch plug. If you continue to clamp the same part, there will become fixed dents in the tubes. In this case, while the clamps are still clamped, blood might be removed. The clampers will deteriorate with frequent use. After catheter placement surgery, we use a syringe to check for defect in the original clamp occasionally. Original clamps and repair clamps have the same shape and strength. The repair clamps has two narrow catheter passage and slits, but the original clamps are wide passage. Only 3 points is easy to repair. First, move the clamps to near the center of the line. Move the clamp to the center of the clampable area. Pinch the connector the branch so that the clamp is exposed. If you cut the 4 parts with nippers and pass the finger squash the branch through the central slit so that it is distal position to be clamped holder. We fit the longer arm of the clamp holder into the large recess of the clamp. Finally, insert the branch pipe crushed with our fingers into the slit. Cut 4 places with nipper, removed, and over there, we prepared repair clamp. Please check the actual repair clamps directly. Thank you for your attention. Thank you very much.
The next is the polyurethane. Polyurethane is to be the benefits from the silicone is to the too difficult to the kinking and can contact to the polyurethane, but to the careful to the contact to the alcohol to the change of the structure of the polyurethanes. The next is the polycarbonates. It usually now to be the use the polycarbonates in the mixture to be the polyurethane and polycarbonates. The carbonate is to the anti-kinking and can not affect the alcohol and polyiodine. Yes, it's now mostly material is carbotane. In the structure of the cuff character is the Dacon cuff, and it forms the polyester. The function is to the enclose the tissue in the cuff after the insert, and you can see the tissue to enclose here to fix the catheters and to prevent the infection from the exit side. Site of selection. Basically, the anatomical you can remember from the internal jugular vein. The serous triangle. Serous triangle is to the between heads of the sternocleidomastoid, and the lower is the clavicles. It's the serous triangle. The internal jugular vein is the inside here. Another anatomical function to the approach the supraclavicular subclavians. Sorry. Its landmark is about 1 centimeter to lateral the sternocleidomastoid and 1 centimeter above the clavicle to the point of sternal angles. It's a landmark to the approach of the supraclavicular approach by the anatomical technique. And the position in the proper in the patient to be the insertion. It should be the Tendenberg position to be the increase the diameter of the internal jugular vein and extend the neck to be the easy to cannulate. Head to contralateral side of the puncture, but not too more the contralateral sides, because the anatomical of vein and artery relationship is to be changed. If unable to the Tendenberg, the Valsalva or humming is done to increase pressure to help to enlarge the vein to easy to cannulation. Operative table to the position is the Tendenberg position in the head, in the leg that is this side. And the head link to easy to fix the head. And the pillow behind the backs to the extent to easy to approach the neck. Not too much turn head to the opposite side, because usually internal jugular vein is the lateral to the arteries. When you too much turn head to the opposite side, the anatomical and the anterior internal jugular vein to be anterior to the arteries. When you puncture in the anterior approach, maybe easy to the injury to artery then. The approach to internal jugular vein can be the anterior to lateral approach. Anterior is the serous triangles, and the lateral approach to the lateral to the sternocleidomastoid. And the low insertion and the high insertion. In the high insertion, maybe the difficult have the acute angle. Sometimes acute angle to be the kinking of the catheters to be the effect of the function. If to load the insertion, maybe the smooth curve to the not interfere the anatomical of the catheter, maybe if, to good the function. The puncture of vein is the needle about 1.5 inch at the tip, slip tip syringe. Yeah, it's slip tip syringe. Recommended the 10 ml slip tip syringe with 2 or 3 ml syringe inside. And the 5 slip tip syringe is not recommended because you struggle to fix the introducer needle. And lower lock syringe usually in the set. Yes, it can control fix to the catheter when you're testing the function. It should be not use the puncture when you puncture because to the difficult to the push off, maybe the change of the position of the needle. And the needles have the bevel to the tip, and we have the marker to points of the bevel position. When you cannulate the vein, sometimes the bevel is partially inside the vein, not completely from the tending of the vein. This you can push, you can free blood from the in the syringe, but the bevel is not completely. Next, you can fail to the guide wire insertion to the not inside the vein, to the outside. You must completely bevel into the vessel. That's this. After you the bevel to completely inside the vein, you should recommend the rotation the bevels about the 90 degree to the bevel direction to control to the heart. You can easily the position when you guide wire advance into the right atrium. Yes. The wire preparation to be you see that the curve in the tip to be the prevention to the injury. But before you cannulate, you should be prepared already ready to use. That's here to stay the tip ready to use the cannulate in the needle. You also want the nose to control the tip. Yeah. Some commercial is the thumb dice to control the wire. Yes. To put off the wire, put down, can do state the tip to the prepare, ready to use. And the basically technique is modified syringeal techniques. First is the cannulate, puncture in the vein, and advance guide wire to the needle to inside the vessel. After that, the remove the needle and push off the dilator over the wire to dilate the tracts, skin to the vessel. After that, you push the catheters over the wire, push into the vessel. It's basically modified syringeal technique. Okay. The puncture is to be two techniques in the previously by anatomical landmarks and the ultrasound guides. Yeah. Usually now the ultrasound guide is the standard technique, but in the by anatomical landmark not difficult but may be useful when you urgency but no not available ultrasound to use. Next is vertical out of planes. It's by the anterior approach. You can see by the cross section of ultrasound is the interjugular veins in the carotid artery, thyroid, and when you push the needle, you can hit the density in the point of the needle in the field. But the lateral axis in plane techniques, you can see to different from the previously. The video is show to the techniques in the short axis lateral in plane. It's the arteries, it's the interjugular veins, it's the sternocleidomastoid. After the inject the local anesthesia. Sorry. Okay, you can see all of the needle. And now you local anesthesia. And the lateral approach and compare the approach to the anterior approach. The lateral approach to be the lateral needle, to be the border of the sternocleidomastoid that's here, and this to be compared the anterior approach to the anterior. I think the chance to be the injury to the artery may be too careful. Another is the PVC technique. After you puncture and to the wire into the needle and the dilator, and finally the PVC is over the dilator to push over the wire. After you remove the catheter, do the dilator, you have to push the catheter into the PVC and the base of the PVC. Yes, and push up the PVC and the to the completely. That's here. And to check up the tip of the catheter in the proper position in the right atrium by fluoroscope or the film X-ray film chase. And locked by heparin 1000 units per ml concentration. Okay. Okay. Thank you for attention.
Not suffer when you puncture to the vein, because I think that the key point that the rule of swelling may be to when you success to puncture to the vein, but you fix maybe the nurse assistant fix the swelling, rule of swelling, and you cannot to remove. You success for puncture, but cannot remove the swelling before insert. The guide wire may be stuck for you for further puncture. That slip tip is a very good idea for insert. Easy to slip the tip of the swelling before the insertion of the insert the guide wire, and you see that maybe you puncture to the vein is success, but you ignore to see the guide wire when you can use the ultrasound to check, because you success puncture the vein, you success, but you maybe not surely the needle is still in the vein, but you push the guide wire into the vessel without ultrasound checking, and you further to a dilator to the outside the vein to the outside the vein may be injury to the structure. And Dr. Yuthapong have the good idea for if you puncture from the anterior approach is direction is a puncture from the anterior, maybe to success puncture to the IJ, but maybe you cannot to fix here, and you use the guide wire, maybe puncture to the carotid artery and level load the guide wire freely into the artery. That may be to a cannulation, not IJ, but carotid artery. Very, very good step. That meaning that the lateral approach, you see that is the different the pain. That meaning the artery, the carotid artery is in the ground floor, the first floor, and the IJ is the second floor. You puncture lateral approach is the second floor. Above, not here, but if you puncture from the anterior, maybe to the above the second floor to the first floor to injury the artery. That the technique of lateral approach, or the meaning that I to show in the model in the workshop in the Dune to many technique to insert the different pain and different technique for the model that the Nippo make from the base the base model for you to training. Okay, yes. Successful for the insertion technique for instrument that Dr. Yuthapong said that there is a puncture site. If you have the ultrasound and the fluoroscopy for two direction of the wire into the heart or into the IVC is very perfect for you. But in the ICU, not fluoroscopy. In the bedside puncture, you know, fluoroscopy to move to the ICU for you to see the complete wire insertion that the guide wire with the ultrasound bedside is very important for you to see the guide wire for success, not miss guide wire. And if you make the tunnel cuff catheter, that the tunnel creation is very important, because the tunnel catheter is have the stage type and the P-curve type that Dr. Lida show you in the Nippo product have the both of the curve, the P-curve and the stage type for use. And the exercise may be important, because if you make the exercise medially, it may have the more kinking, but the more the lateral is not suffer. It suffer for the patient because it's near the axilla to movement. The patient cannot movement. It may be to disrupt of the catheter. And the size of the cuff is very important, because you insert the catheter inside, but the cuff may be near the exercise or beneath long deep to the tunnel. Because if you nearly exercise is nearly exercise, the cuff is nearly exercise, is rate of infection is more than 4 times. And if you make the cuff is too deep in the cuff, is more infection too, because it cannot the deep of the infection from exercise it go up to deeply. and the team is very important. The training and assistance and experiment for you for fully team. Oh, sorry. I want to show that the tip and trick for tunnel catheter insertion. I write this model because in Thailand have the state catheter, not P-curve like a nipple to present. That meaning that the curve here very important is puncture site. The 45-degree puncture site at the IJ here to make the good curve of here and the exercise in the lateral at here. That meaning that if your puncture high is high puncture site, that you will see the acute angle to the apex of the curve here. That is very important to kinking. That the P-curve catheter may be to solve this situation. But need to make the smooth curve very important to smooth the curve here for no kinking of the catheter. And Dr. Leader talked to you that the right atrium in the right atrium tip is very important, and maybe to study about the shape of the right atrium too, because the right atrium in every patient is not the same. It's not the barrel chamber. It may be the triangle, the triangle shape, maybe the barrel shape, maybe the tubular shape. That meaning that the pace of the catheter may be to the position, the shape may be suffer for use. Very important because this pre-operation, the film chest, maybe you maybe ignore to see that the shape of the right atrium may be to tubular. The tubular may be need for the long length, deep more than the barrel, because the barrel is the last one. Is you can push the catheter into the center of the chamber is easy, but the tubular, the small tubular, if you push to not deep into the maybe to suckle from the sucking wall of the wall of the SVC or the right atrium, that the tubular shape. Very important here. And you see that the exercise here about 2 or 3 centimeters deeper from the exercise, that more 4 times infection if your cuff is near the exercise here. The puncture site that Dr. Yuttapong said to you that the key point that the first in the right IJ, the first, and the approach to the lateral to see all the tip of the needle, not only point, because you puncture at anterior approach, you see only the point of the needle, but you don't see the tip. The tip may be insert into the artery, into the outside the vein, but you can see the point of the needle into the center of the vein. And this is because you know that some doctor send to you maybe the second procedure or the third procedure, and pass from the IJ right and left side both, and have the thrombosis both intrajugular, maybe have the approach from the supraclavicular subclavian vein for the practice, the last puncture site, and you can use the probe ultrasound probe, will move up and down the head inside to the interthoracic part. You can see the supraclavicular subclavian, and you can see the innominate vein too. When you use the heart, the vascular probe, normal is 12 or the 14 megahertz. But if you want to see the deeper, that meaning that you use the ultrasound maybe to have the two probe. That I like two probe. The basic probe maybe to 9 to 12 or the superficial megahertz. But the low megahertz about 7, maybe to deeper for the probe to move to the innominate vein for puncture and use the you can use the probe, and you can see the innominate vein, and you can puncture with ultrasound and short axis lateral in pain technique to like a basic to IJ. That meaning that you will success for puncture any vein in the body with the three technique, that short axis out of pain technique, short axis lateral in pain technique, and the long axis in pain technique. T technique for you to insert any vein, femoral, subclavian, intrajugular. You can see when have the training in the next session. That you show yes the puncture the femoral, and the femoral vein. You know that in the groin the vein is superficial, but in the vein for the external iliac vein is the deeper, is curved, is curved because the vein is in the rectoperitoneum space, is curved. That meaning that the guidewire that you insert is curved too, and the dilator may be to injury and have the extra anatomical extra vascular and have the rectoperitoneum hematoma and suffer from the function. Very important. And the size of cup, I talked to you that if we're good for 2 or 3 cents, and this is a 5 cents milliliters for the exercise wound infection, and it's not a 1 cent. It may be a list infection too. Yeah. And I study the lipo sperm cat, the cup catheter. That I see that the trick is here is a P curve that I show you in the model in the next session, and you see the marker at the 10 is here from the tip, and this is the spherical tip. The lipo is the spherical tip. You can use in Thailand, and to have the palindrome catheter is the same spherical tip, and have the spherical tip from the lipo sperm cap, and this is 10, 15, and this for 20, and this is for 25. That meaning that the cuff here, the cuff at here it is 21.5 cent. That meaning that it is the curve at the puncture side, and the puncture side here to the tip is about the 17 or 18. That the side from the puncture site at the apex of the cellular angle to the right atrium is the height of the Perez formula. the Bayes formula that the formula that the apex from centroid triangle to the ATO cover junction that the height divide by 10. That the height of the patient is 160 centimeters. That meaning the length from the puncture site to the ATO cover junction is 16. That's the meaning that here to sure that the tip and the puncture site here is about 17. That meaning the tip is in the right atrium. Sure, it's good. That you show that it's good for the cuff here and the 2 or 3 centimeters here and exercise. That show that you see that the nipple catheter is if you have the 2 or centimeters above here, it is a good exercise. If it is the lower of the cuff of the nipple catheter, and you see that this is the marker for the exercise, the good exercise marker for you, and have the 1 or 2 is a point for 1 centimeter here. That the meaning that you can make the exercise here and here and here and here. It's good for function and the good for embed the cuff here like this. It's good. Okay, I talk to you. And the side of tip, I talk to the curve. That I talk to the curve is very important. That not kinking here, and the tip in the light atrium. You see that is the barrel shape of the light atrium is go to the center of it's good function. But some case maybe to have the tubula of the light atrium maybe to sucking or one side. You can if you make maybe a sucker from the aspiration for one side, but the symmetrical tip is the same for no recirculation. You can split from the A to V or V to A channel. It's good for no recirculation for use for the patient. Yes, if you see that it's a high puncture is a kinking. It's a kinking here. That to make the centimeter is very important. And I make the puncture to a middle insertion to the lower insertion. But if the nipple puncture at here is very very high, but it's a P curve maybe useful for the long length of 28, maybe to use for the catheter for P curve. But maybe suffer the patient because you show that the high puncture and have the curve, and you want to the market to anything else to show the neck is not comfortable for the patient. This Dr. Yuthapong talked to you that the posterior puncture and no injury to the artery is to see the all of the needle tip, all of the needle, no injury. And I practice with the technique from the lateral approach and no injury to the carotid because see the tip into the vein. Yeah. And I talk to you about the Bayes formula is the height and the length of the apex of the centroid angle to the ATO cover junction. Yes, here. This is Bayes formula for the catheter for the light intrajugular. It's a height divided by 10. It's from the apex to ATO junction. But if you puncture lower, if you puncture for the tunnel cuff catheter, you puncture at here or at here. That meaning to lower about 2 or 3 centimeters from the apex. That meaning that the length from the length of Bayes formula from the apex to ATO junction. But if you puncture here and the length is to the right atrium, it's the same. You know, length here to ATO junction, but you puncture lower, that meaning that the length is the same into the right atrium. It's a good function for you that not suffer. Okay, yes, you see this I arrive here is to cut point from the 160 centimeter height. Okay, yes, okay, no thumbing, yeah, okay, yes, and if you have the lower exercise is wrong, and have the pendulum base, the last base from the patient, you very important. If you have the last base is to stuck, the catheter is go up, and the catheter tip is cannot to proper function. Very important here. Yes, very, and this is for kinking. Yeah, the curve is very important to make. Yeah, the lateral approach to see is okay, and failure the right IJ. Don't use the catheter that you open to use for the left side is not proper length. Okay, yeah, because it maybe have the tip malposition and cause the catheter dysfunction for Dr. Lida talk to you. Yeah, and it's a supra-solenoid and it's a lateral approach. You see, this is the lateral approach to puncture because horizontal pain, and puncture to the IJ lateral approach. That meaning you stay in this fall, not the cow fall. You drive the needle into the board, not the below. There's no injury to the structure. Okay, and the technique is you see that if you have the dilator into the vein, pull and push guide wide, very important, because if the dilator that you stuck to the wall is hard to remove the guide wide. It's stuck here and cannot easier to pull the guide wire back. That meaning that you be suffer maybe injury to internal of the vessel, and maybe to push off the dilator and push to out and injury to the magnum, the patient. Okay, and some product with other maybe have the stylet, the single stylet, double stylet. You can to learning about the stylet too, because this is the stylet have the guide wire inside. You can pass the guide wire inside, and you have the stylet here, and this is the catheter. This learning for load the catheter. And thank you. Okay.
This slide is a modality of vascular access in Japan. Recently, AVF is about 90%, and tunneled CVC is 1.4%. Recently, a Japanese patient, the age, introduction age is elevated, and there are many dialysis diabetes patients. So the percentage of TCVC is elevated recent year. However, 1.4% in Japan. And this is today's agenda. At first, I'd like to introduction of CRBC. From GSTT guideline, the catheter infection was divided three types. exit site infection and tunnel infection and intraluminal infection. Today I talk about this type 3 infection. And a general overview. Test required when an infection is suspected. Tests required if any infection is suspected is revealed this slide. However, blood culture is very important. And the significance of collecting blood culture is this first one. Blood is inherently sterile, so bacteria detected equal infection causing bacteria. This is an important point. And conditions for which blood cultures should be collected is fever and fever, shivering, unexpected decrease in blood pressure, unexplained hypothermia, and all. And the key point of blood culture collection is these three patterns. Timing of blood collection and number of blood culture sets, amount of blood to culture. At first, what is the optimal timing for blood collection? This blue line is amount of bacteria in the blood, and this red line is temperature, and this line is times, and the chill is now. So a golden period is 15 minutes. Because bacterial culture should be taken at intervals of no more than 5 minutes. The reticular endothelial system causes transient and bacteria is treated in 50 to 3 minutes. So this is a golden time to blood culture. And between first culture peripheral blood and from catheter blood is the between within 5 minutes is better. And the relationship between symptoms and bacteria and cold and chilled and shivering. And this research is percentage of positive blood culture by each symptom. Shivering with cold is 27.7%. So no symptom is 20.0%, 2.0%. And this is a number of blood culture sets and a positive rate. And one bottle is 73.2%. However, 2 bottle, 3 bottle is almost the same. So the set is more 2 set is standard. And optimal blood collection volume. Too little or too much blood decrease sensitivity up to 30 milliliter blood volume is detected proportional to detection rate. So for one vein puncture, 20 to 30 milliliter is better. And at this slide, what is infection rates of couch type catheter? And right is USA data, and left is Japanese data. And AVF is ratio is 1. So couch type catheter infection rate is Japanese data is 1.15, and USA data is 3.69 rate. And tips for catheter infections. Question number 1. 33 years old. He's hospitalized for Crohn's disease and high-grade fever. How do you correct blood culture? Dr. Ida? Okay. Three. One set each from peripheral and central veins is correct. This is a diagnosis of CRBSI. One peripheral blood culture and catheter blood, or herb or chip culture are positive for the same organism. And second, catheter blood culture more than 2 hours before peripheral blood culture. This is called differential time to positively, DPT. About DPT, amount of bacteria in catheter and amount of bacteria in peripheral blood. This is more in catheter. Early culture positive and delayed culture positive. So more than 2 hours early diagnosis of CRBSI. And this is a definition of KDOKI and CDC and IDSA. Almost the same. To set culture, peripheral blood and catheter blood is same organisms, and 2 hours before cultured, or a number of colony count method is there, which is same. And bacteria causing CRBSI is this slide revealed. High frequency of gram-positive bacteria, so VCM is often empiric therapy. And treatment of CRBSI is removal of central venous catheter, and empiric therapy is treatment of CRBSI. And question 2. This is 33 years old male and high-grade fever. And the next blood culture detected suspected Staphylococcus aureus. Which of the following is inappropriate response? Dr. Ida?
Yes, number 3.
Correct. Yes.
Thank you.
Inappropriate response is administered until inflammatory response become negative. Because this is a recommendation in treatment duration for CRBSI. The treatment duration is determined by the bacteria. So if there is no symptom, negative CRP is not a criterion for a discontinuation. And question 3. Blood culture results Staphylococcus aureus. Which of the following is the most appropriate therapeutic agent after the identification of the species? Please, Dr. Ida.
I use meropen, but correct is 2.
Correct. First line antibiotics after indication of the organism is determined. So MIC value does not matter if sensitive. Do not choose a lower one.
Oh.
This is recently point.
Thank you.
And case presentation This case is not a dialysis patient. This patient is Buerger disease and ASO patient, and type 2 DM and so on. And this patient performed Leocarna therapy. Leocarna is the direct hemoperfusion therapy for ASO. So the first call is January, and the second call is June. And second call, the first day, he developed fever a few hours after Leocarna therapy, and the increasing inflammatory reaction was observed in blood sampling before starting blood purification therapy. The patient was urgently admitted to hospital because of strong suspicion of catheter infection. And this is data at the hospitalization. Blood temperature is 40.9 degrees, and the WBC and CRP inflammation marker is elevated. And septic emboli was suspected on CT. This arrow mark is septic emboli suspected. So I'm sorry, this category is not Nipro company. This Centros Pro catheter. And immediately removed at night, removed the catheter, and chips cultures are also submitted. And culture results. All papillary blood and catheter blood and catheter chips, all is Staphylococcus aureus. And this is important. The peripheral blood collection is the time to a positive sample is 30.4 hours. However, catheter blood is 10.8 hours. So CRBSI is determined. And this is sensitivity of antibiotics. So this is Staphylococcus aureus. So we choose BCM and Melpen, and for this is for fungid. And this slide is from KDOC guidelines. And treatment strategy for CRBSI or bacteremia. And this is removing to CVC and retracting the CVC strategy. So in our case, we suspected metastatic complication, septic emboli. So we remove the catheter. This is CVC removal with a new CVC replaced new site plus minus CVC free duration. Two types methods. However, in our case, septic emboli case, so we remove the catheter as soon as possible. So I think I could have done it according to the guideline. That's all. Thank you for your kind attention.